Podcast today, I have on Dr. Nathan Riley to have an open and most importantly, nuanced conversation about abortion. Dr. Riley is an OBGYN and is dual board certified in hospice and palliative care, so he offers an interesting perspective of expertise in both the beginning and the end of life. Our goal in this episode is not to take sides, but to explore the shades of gray in a topic that is often painted in black and white. This conversation may not be for everyone, and that's okay. It isn't a perfect discussion, but we hope that you'll find something in it that resonates, challenges, or simply helps you understand the realities that others face, realities that you may never have had to think about, which itself can be a type of privilege. We truly believe that most people likely fall in the middle ground space if only we could share the perspectives from both sides. Conversations like this are not easy, but keeping them open and honest is the only way that things can change. So we invite you to listen with an open mind and open heart. Let's dive in.
Welcome to Healthy as a Mother, the podcast for becoming and being a mother, with your co-hosts, Dr. Leah Gordon and Dr. Morgan McDermott, two naturopathic doctors who get it.
Each week, we teach you how to be the healthiest mother you can be, from fertility and preconception to pregnancy and birth prep, through postpartum and throughout motherhood, empowering you with the natural health guidance and education you're not getting elsewhere, so you can confidently navigate the broken system at large.
The real, the raw, the untalked about. And remember, this information is not intended to diagnose, treat, or manage any disease. Always consult with your doctor before making any changes.
The metabolic needs of pregnancy, postpartum healing, and making breast milk require more minerals than in other times of your life, and staying truly deeply hydrated during these times is very important. Nowadays, there are more options for this than ever, and ingredient quality and manufacturing integrity is very important for Dr. Leah and I. That's why we love Redmond Relight electrolyte powders. Mined in the USA, Relight contains Redmond's ancient unrefined sea salt with 60 plus trace minerals in addition to the appropriate proportions and forms of calcium, potassium, chloride, and magnesium that pregnant and breastfeeding moms need. Pregnancy demands a huge increase in blood volume and synthesis of an entire new baby, and that requires, you guessed it, minerals. This is the perfect blend to be sipping on during your labor or to have mixed into your bedside water bottle during breastfeeding. It tastes amazing, and my favorite flavors oscillate between mixed berry, strawberry lemonade, or lemon lime. Grab a sample pack option to try them yourself and use code HEALTHYMOTHER for 15% off your order of any of the products that Redmond has to offer, including their OG sea salt, other seasoning salts, natural toothpaste, bentonite clays, and more. Happy hydrating! Okay, so welcome to the podcast, Dr. Nathan Riley. I really appreciate you being here for this very nuanced, important, and very just human conversation. We are not touting to be experts in this field or the legality around abortion necessarily, but we want to have a human conversation that bridges together some of these gray pockets and areas that are not being spoken about when these topics come up in the media, and how also some of the laws, legality things might affect people, where there might be just misunderstandings in terminology or situations that can happen. And now from a clinical point of view, which is your expertise, what could be things that others haven't thought about. So before we get going, can you please introduce yourself? And also all of your information will be linked in the show notes so people can find more about you, because I think you're very worth knowing about and a good follow on social media, also to check out your program. So go ahead and tell us who you are, what your background is.
Sure. My name is Nathan Riley. I'm an MD trained at the University of Pittsburgh, and then I went to med school at Temple University, did my OBGYN residency training program, which is a 4-year program at Los Angeles Medical Center at Kaiser Permanente in Los Angeles. And then I did a year of fellowship in hospice and palliative medicine at University of California, San Diego. I've got 2 little girls, married to my high school sweetheart. And I've performed a number of abortions in my training, and I've supported medical abortions outside of my training. And I have a unique position of authority to speak about this, even though I will never be pregnant, and my body will never go through an abortion. I have a lot of opinions about this, but I'm hoping that we can utilize clinical sort of case studies in order to illustrate just how complicated this topic is, and how it is not as simple as saying abortion is murder and anybody who does it is a bad person. There's a lot of really, really important scenarios that fall in this area, and this gray area. And if we can approach this conversation, you and I, Morgan, and the listeners, if you can just approach this conversation with an open heart and an open mind, around the nuance that is required of such a complex topic, I think that we can all benefit a little bit here today. So thanks for having me.
Yeah, thank you for saying that. I want to just even reiterate more that this is not going to be a pro-life conversation. It's not going to be a pro-choice conversation. The intent is to bridge the gap between those two ideals and say, how can we understand our neighbor better? How can we maybe come into a little bit more of a centered philosophy of getting that this is really complex? Even in just on my socials and talking about this episode coming up and recording this with you, somebody had written me and they were like, it's the ending of a life. It's really not that complicated. And I was like, okay, it is. It really is that
Yeah,
complicated. So, you could tell where she was coming from in a very
sure.
pro-life
We've
manner.
all heard it.
Right. And so we are, probably going to miss things. This is not going to be a perfect conversation. We just implore you to, like you said, have an open heart and mind, knowing that the intent is not to be radicalized or extreme. It's to actually bridge and bring things together, understanding how can we have reverence for birth and life while also intersecting that with reality and
Yeah.
people's limitations and even the medical and health side and complications side of things, the feasibility for mother and baby to make it work, and highlighting that this is not something that is like flippantly used. I mean, obviously there probably are people who just have had 9 abortions or something and they just use it as birth control. I don't think that that is the majority of what's happening, although I think that the media will bias spin that in whatever
Yeah.
direction to make it seem that way. And it's that if that's all you ever hear about it and think about it, I can understand why, yes, there's a moral issue there. And I think everybody would agree that there's a root cause problem that needs to be fixed there if that's the way that this is being used. And it's not being used that way. In the majority of the sense. And so we want to kind of highlight that, but also even highlight some of those root cause problems. Like, what are some things that need to change in our society so that we're not getting to this point, maybe with that's like women understanding their menstrual cycle better, understanding that when we go into this contract of having sex, there is always this outcome and whatever, sex education, reproductive education, understanding your body, being really empowered, having tools and ability to get different birth control options, etc. So we can kind of just like take off. We're going to just riff on it. I'd love to know if you have any, having your experience is huge because I'm sure that you've thought about this a lot. And one question I have for you to just right out the gate is, in your abortion training in medical school, is there moral conversations or ethics classes that go around with it? Or is it all just, this is the way that it's done in more of the medical technicality sense?
Right. Yeah. So let's talk about how a person becomes an abortionist, which is the term for somebody who performs abortions. And we have different types of abortions. We have procedural, also known as the surgical route, and then we have the medical abortion route. Um, in order to sort of start to answer that question, we have to appreciate what is it, how does a person become a doctor to begin with? And you go to medical school, as you mentioned, but medical school is not really where you're doing anything. You're not really doing any surgery. You're not doing any prescribing. You're there to learn and to clean up and to be available, at any moment when a teaching moment arises. If you're in medical school and you want to go into obstetrics and gynecology, you might find yourself volunteering at a Planned Parenthood or a reproductive health center, as some of them are called, which is separate from Planned Parenthood, but is basically the same type of center. And so you might get to see one. You might even go into med school hoping to someday be a person who offers abortion services. But it's not until you get to residency that you're actually having your hands on the instruments and doing the thing. So in med school, the answer is no. You're probably not getting a lot of that type of conversation because you have to bear in mind, you have to learn. It's about a textbook. I mean, a thick textbook every 2 weeks that you're pounding into your brain. Which is in and of itself a weeding out process. There's a lot of people who get to med school and then just decide this isn't for me. And that's a really, really expensive and hard decision for people to make. And I'll take the opportunity now to say that before Roe versus Wade, which I believe passed in the Supreme Court in 1973, before that, for years and years before that, if people were seeking out an abortion, you had to go and find what they used to call like the back alley butchers and these types of sort of superlatives. And the people that were doing the abortions were not associated with academic hospitals. They were not freestanding abortion clinics advertising this. They were people who probably were not fully licensed or capable physicians, med school dropouts, that type of person, who actually could perhaps offer a safe abortion, which is not rocket surgery to many women. But then we also had, because of its secrecy, we also had women who then needed additional care that couldn't get it, from bleeding to organ damage because something, an instrument, went in the wrong place, or you had infections, right? So after Roe versus Wade and in the decades to come after that, we had people who actually were trained not just as OBGYNs, but they did extra fellowship training in what we now call advanced family planning. Now, fellowship is, in addition to your primary specialty, you actually spend a couple years doing just that thing and all of its different machinations. And so at this point in time, or at least when I was in residency, one of those fellowship paths was this advanced family planning, where you're not just learning about contraception and the diagnosis of miscarriage and the management options for first and second trimester abortion. You were kind of immersed in the ethics and the sort of bioethical principles of this. And it's also an important time to remind everybody that there are people that started doing that before Roe versus Wade, and then they actually had permission to offer that on a more mainstream platform, so to speak. And those doctors are frequently abused by the public, by a small minority of the public, who feels that they are monsters for offering options to women who are carrying unintended pregnancies, or even pregnancies that might be putting their own lives at risk. And if you go to a Planned Parenthood, you oftentimes see the picketers, but there's a back door that people come in and out that is heavily guarded, because there was a Dr. Tiller, I can't remember what year this was, but he was like execution style, as he was going into work one day, and so the people that are doing this are putting their lives at risk, which should actually be a little ear prick for people. That the people that are out there trying to save the lives of babies are actually out there also looking to potentially bomb or execute physicians who've gone through college, med school, residency, fellowship. And it's not because they just want to be seen as monsters. It's because they see reproductive justice, which is a relatively new term, as a non-negotiable in medicine. And there's no other field or subspecialty that has so much division around it, this abortion thing. So your question was, do we learn about the ethics and this and that? Yeah, I think actually it's a part of doing the work. And I'll tell some stories later, but a second trimester abortion, generally after, let's say, 16 weeks or so, which could be for a variety of really important reasons for both baby, mom, the family, etc. It's not just, oh, you know what, I decided I didn't want to have a baby. Just take my baby out. Kill my baby. Like, that's what people think. That procedure is called a dilation and evacuation. And there are ways of doing this where you get the baby out intact. It's not very common. You could induce, but that's not as common. The way you do it is you grab and you pull, and the abortion happens. I have a family member who went through this, which I would love to share that story at some point. But when you're doing that procedure, everything you ever thought you knew about like your humanity is drawn into question. So much so that somebody like me decides, I really can't do this. I know that there are good reasons. And there are great people, great doctors who will pursue a fellowship in this in order to be able to offer this opportunity for people to preserve their own health and their own family unit, because they want to do this thing that even I would probably not be able to do. Like if it was my wife and I. So naturally, by virtue of you doing these procedures and getting to see it and spending time in Planned Parenthood, all of the ethical considerations come up. And yes, you do meet that occasional person who's like, oh, my whatever, I had this thing, I went to this party and I got pregnant. And I don't want to be pregnant right now. And they take it like as if it's like, selecting what type of milk you want at the store. Like, I'll just have that type of abortion. Like, yeah, some people do that. But that is a a fraction of the number of women who are benefiting from those people who've gone the extra 9 yards to become an advanced family planning specialist, who's then also putting their own life and their family at risk by simply offering women's choices. The last thing I'll say is that we do a poor job of understanding bioethics to begin with and what's required for us to support the autonomy of Morgan or any other woman to actually have some say over what happens to their body. And the same people that are coming after you or me or whoever, hunting down these doctors and harassing them in their workplace, maybe even sending death threats to their family homes, might say, yeah, women deserve a right to have a baby at home or a free birth or whatever else, but they draw the line somehow around a woman's autonomy when we're talking about abortion. And I know why, because now there's another life there. And this is a low-cost initiative that has been politicized through religious fundamentalism and the Dems and the Republicans. Everybody has something to say. Well, where are the clinicians? The clinicians sometimes are even afraid to speak up because they are afraid that maybe somebody's going to come and try to execute them. This has gotten completely out of control, but we don't learn a lot about the ethics of this in med school. I think it's sort of assumed, perhaps, that maybe we've been deeply thoughtful about the ethics of how to care for people by the time we get there. And then as you go through your training, certain things come up and you're like, oof, this doesn't feel good. That happened for me in how we manage childbirth to begin with. And pretty much everything that follows, everything related to women's health. And that doesn't mean that I'm pro-life or what's the other one? Pro-life, pro-choice. Everybody's pro-life. Everybody wants to see women and babies and families thrive. We all want to see life flourish. The problem is that there is a number of situations that arise in this gray area that really require us to not become automated regurgitators of what we hear in the media or from our pastor or from our friends or from the Instagram, universe. It actually requires us to be human beings and consider what is the greater circumstances around which maybe my perception of abortion might just be not adequate. And that's what I hope that we can get into today.
Yeah, thank you for that. That was awesome. I think it speaks volumes, the idea to be able to be confronted in a scenario like you were talking about with the dilation and evacuation and say, this is not for me. And then although people will learn this about you with following you more, you are an OBGYN, but you work heavily outside of the traditional, conventional obstetrics model. You work with midwives. You're all about, so it's been something you've pulled away from in different ways. And I love that you also highlighted the hypocrisy that we can see between certain groups of people rallying for some rights and then not for others.
Yeah.
And
Yeah.
I think it's so much to do with misunderstanding. I often have these thoughts. It's one of the things that I have always had a natural skill in, and I think it's because I'm a Libra, but I feel like I can really sit there and I can put myself
balancing
yeah,
act.
exactly. I can put myself in the situation of somebody who's extremely pro-life and I'm like, yeah, I understand what you're saying. You're
Yeah.
right. Like this is it's horrible. It's sad. And then I can look and I can put myself in the situation of somebody who's pro-choice or is faced with the decision making and how hard it would be. And I can also say, if I was a teenager, if I was in a domestic abuse relationship, if I was, whatever these different, obviously, if my life was at risk. And actually, one statistic I came across in preparing for this podcast was that 52% of women who are seeking abortion are already mothers. And so
Isn't that
that's something
interesting?
to be thinking about, that half of them already have children. And if there is some sort of life threatening or medical complication going on where it would be beneficial to end the pregnancy, or even a life circumstance situation. Like I've never, luckily, thankfully, never been so financially unstable that the addition of another child would break my family and we'd be
Sure.
out on the streets. But that is something that happens to people. And thank
Right.
goodness for those that have never had that issue. They've never had to think about it like that. And that's really, really lucky for you. And I think we need to be able to have some more compassion that there are situations, although you disagree.
Right.
Some people, not you, but some people would disagree. They'd say, no, you need to find a way to work. You can put up for adoption. You can do different things. Yeah, sometimes that doesn't feel feasible to that woman in that moment. Although you can still say, I disagree, you can also look at her and say, I understand and I support you. And I not support you in that like rah, rah, I'm cheerleading for you. But like woman to woman, human to human, you were faced with an extremely difficult decision and you did the best you could. Also, knowing that many, many, many women who get abortions, although they chose for the best of them, their situation, their family, their circumstance in the moment, have a lot of regrets and a lot of shame. And it's not
Yeah.
something, and they carry it for their whole life. It's not like they don't care. And of course, like you said, there will always be the person who's very flippant about it. It is just not the majority. And so I wanted to bring that up. And then let's even just dive into some of the medical things, because this has been a place of pushback that I've received on socials, which is that there's, this idea out there that there's no situation where a medical complication would put the mother's life at risk outside of ectopic pregnancy. And just for anybody
Right.
who's really new to all of this, ectopic pregnancy is where the baby implants in the fallopian tubes or anywhere outside of the uterus. Sometimes it
Right.
can even be in the abdominal cavity. It's not as common, but the egg and the sperm meet in the fallopian tubes. They don't meet in the vastness of the uterus. They meet in the fallopian tubes, and then that little ball of cells divides multiple times. And as it's traveling down the fallopian tube, it now becomes this like little bigger ball of cells, and then it implants into the uterus. This is in a normal sense, and it becomes an embryo and it starts to do its thing. Now, if something, it happens every once in a while, it's not common, thankfully, but if it decides to embed inside of the fallopian tube, or again outside of the uterus anywhere, and begins to grow, it's not supposed to be there. It puts pressure on the system. It can rupture the fallopian tube. There's a lot of blood flow now involved with placental development and just in general, and
Yeah.
the woman can bleed out. Certainly the very, very early 6 week, 7 week embryo is never going to be viable or make it, even if it has a heartbeat. I have a friend who had an ectopic at 9 weeks. She had no idea until it was starting to rupture at 9 weeks pregnant, and it definitely had a heartbeat, and that's horrible and sad. And she was very cut up and sad. Now she has one fallopian tube. She almost died. She just had no idea until it was to that point. So
Right.
ectopic pregnancies, I feel, are understood across the board, but there are other situations. If we can talk about some of those for a moment.
There's 2 points that you brought up that I think we actually should put a little more emphasis on. The first is that we live in a community at large, a society that is largely fragmented, it's siloed off, it's extremely inegalitarian. And the reality for many, many, many Americans, especially those living in rural parts of the country, which will bring me to my second point that we need to emphasize, is that there simply isn't a social network that is sufficiently robust to support women in raising children. In other words, hey, you got pregnant, you got to just lay in the bed, that you made and reap what you sow, and you now have to take care of this child. Well, that's fine and dandy for me and for you and many others who, I've got enough of a financial safety net of my own and family and everybody who also has significant finances that if we had to raise another child, we would have no problem doing that from a financial standpoint alone. But what about the mother who's already working, the woman who's already working a day and a nighttime job, maybe on weekends? The amount of money required to raise that baby is going to require a third job or whatever. They're never going to be able to go back to school, which is what we advertise as the means of making more money. We just have a let's say an unstable foundation for families. And so even for those first time parents who have lots of money, they're like, hey, we're finally in a financial position to have children. And that implies that they've been responsible and diligent in not getting pregnant. That's just simply not the case for every single family. So we have to bear that in mind, that I'm speaking from a place of privilege if I were to say, you know what, under no circumstances would we ever terminate a pregnancy, because that's just not right. It's also not right for a woman to end up in complete ruin because the father of the baby isn't involved, or maybe he's not alive, or he's away in war, or whatever the situation. It's just not. It's sufficient for me to say, men, you need to be responsible with where you're putting your stuff because this is a big, giant challenge in many parts of the country if you get pregnant and you weren't trying to get pregnant. And people have sex. Condoms break. Birth control fails. We all know that there's a small percentage, even if you're doing the very, very best you can, including having an IUD in place, which is a part of my story. We got pregnant with an IUD in place and we didn't have many options. We'll talk about that later. So that's the first thing. The second thing is that it's important to remember we can't look at this in isolation. It's important to remember that women who don't have access to abortion services, even if it is a medically necessary abortion, are also those women living in states that have the poorest overall care for women from a healthcare standpoint. We're talking about the southeast of the United States, parts of the, let's just call it the Rockies, that whole like center area that nobody knows the name of every state, the Idahos, the Dakotas, the that whole kind of part of the world, the country, Texas. These are states in which women don't actually get great health care to begin with. So um, this, when you look at this from different lenses, this is actually a war on women's health and on women's autonomy. And so I will say it once and I'll say it 1,000 times. You can't support women's autonomy in a piecemeal way. You either support them or you don't. And that's going to really open up this conversation to some of these sort of isolated case studies. So why don't we start then? Because what you had asked is, can you give me a couple examples? I'll start with our own situation. My wife and I did have an abortion. I had just finished medical school. We were going on a trip with our very, very limited money to Spain to visit her family. And then we were going to head east and stop in Thailand, where my wife used to live when she was in study abroad. We were going to have some like a week there, and we were just going to stay in hostels and do the whole thing as a broke med student. She's a bartender, and we get to Spain, and she has a positive pregnancy test. I was like, oh my gosh, um, what are we going to do? She has an IUD in place. So how is this possible? Well, it is possible. They say that these long-acting reversible contraceptives have like a 98 to 99% efficacy rate. And we had that. I had super sperm. She had super eggs. Like, who knows? It doesn't really matter, but we were in this position. So we spent the limited amount of money we did have going to an OBGYN clinic and getting diagnosed with a pregnancy that had implanted. Whether or not it was going to go the distance is not really what we're thinking about. We're just like, oh my gosh, we're not ready to have children. We had an IUD in place. We did the things, everybody. And I spoke to an OBGYN friend because I wasn't an OBGYN yet. Going back to the med school thing, I didn't know anything. I was just like, oh my gosh, we're pregnant. What are we going to do? And everybody said, you got to take the IUD out because it can cause problems. That's not necessarily what you have to do, but yes, it can cause problems in the pregnancy. There's this big chunk of metal or plastic in your uterus while a baby's growing in there. So when we got back to the States, we then used whatever limited money we could scrounge up in order to go to the reproductive health center in Pittsburgh where we were living. And they removed the IUD, and in the process, it also terminated the pregnancy. So just a part of the thing. But we did say we don't want to have kids right now. Like, this sucks. This is a really crappy position to be in. And that is important, again, to emphasize that even if you don't want to, let's say, even if you don't feel like you're ready to be parents, you don't have the finances, you're in between jobs, in between relationships, whatever else, you ultimately still feel like, gosh, there's something growing inside of me. I don't want to end this. And yet we still had to do that thing. And we still think about it. My wife actually the other day said, our family feels incomplete. Like, there's one missing. Like, maybe that's the one. And I'm getting chills just thinking about it because there's a whole spiritual component to this that is beyond religion. It's like a matter of like the psychic roots of like feeling like a mother and then choosing not to be a mother. So let me then take us to the next situation. And by the way, now that we have kids, I actually had a vasectomy because my wife wanted to have sexual liberation for the first time in her life. And everybody can come at me about that as well. Like, I don't really care, guys. I'm a human being and I do my own things. While we were waiting for that vasectomy consultation, we got pregnant again, by the way, after the birth of our second, which was at home. And it was devastating, So we ended up miscarrying. But at that time, it was harder to decide. And we still already knew, like, we don't want to have a third child. We're not prepared emotionally, mentally to have a third baby when we have two littles under two. They were very, very close together. So anyways, I had a family member who got pregnant after not even trying very hard. Like, got pregnant, and then they were in Europe, and she was like, oh my gosh, I guess we're having a baby sooner than we thought. They had no house. They were working remotely, just vagabonding around Europe. And I had, through my advocacy, through Born Free Method and my sort of way of going about maternity care and prenatal care, I think she had learned, I don't really need this system to have a baby. Like, why go back and forth to the doctor? I don't want to use all of those dollars to go and get ultrasounds and all that. Maybe that's harmful. So she just didn't do anything, just was pregnant. The one thing I did say is maybe you should get a head to toe scan, just like at the 18 to 22 week mark. We call it the formal anatomy ultrasound. And she did in Spain, also in Spain, kind of a coincidence there. And they found multiple anomalies. And they were significant enough that even when I sent images and reports to my MFM friends, they were like, I've never seen anything quite like that. The baby was in early heart failure. There was all sorts of issues with the cardiovascular system, with the lymphatic system, with the central nervous system. This is not a baby that was going to live any semblance of a normal life, if survive to the birth at all. So, the proverbial shit hits the fan. They come back early. I meet them in Pittsburgh, and we're talking about all the options. And they get a second, third opinion from MFMs, and they say, we don't know what this is, but there's not even a benefit to doing like an amniocentesis, because this is unlikely a genetic issue that we can identify. If it is a genetic issue at all, it could just be that like the parts didn't come together right, and we've got a big dilemma here. Now, could she do nothing? Yes. If she does nothing, the baby's likely going to die in the second or third trimester, and she's going to have a stillbirth. But we're before that 23, 24 week mark, which is when most of those late second trimester abortions are happening. And there are some exceptions where you would do an abortion after that, but that is far and few between. Almost never, actually. Like we're talking about 1 in a million.
Right. And people are that's another talking point. They're like, well, anyone can just go get a third trimester abortion. And
No.
they're just using it because, and that baby obviously would be viable outside of the womb, although they would need a lot of medical care. But the statistics of that are, unless you and I are both missing something completely crazy and huge, which I don't think we are, the statistics of that are so infrequent and usually revolving around the baby is already going to pass, or there is now something life-threatening happening with the mother, like preeclampsia. People don't realize that preeclampsia can become eclampsia, and seizures and coma and death are imminent for the mother if the baby does not get out. And does that mean that we have to kill the baby first and then pull them out? No, we can induce, I guess, sometimes, maybe not. It depends on what's happening. But the baby still may not live. And is that considered an abortion? Or is that what they're thinking of? I think that they're thinking somebody gets to 32 weeks, 34 weeks, and
Right.
they just go, I don't want it anymore. That's
Right.
just not
Right.
happening. Okay,
Right.
anyway,
Right.
didn't mean to
And,
interrupt
and,
you.
and even with preeclampsia and eclampsia, like 26, 27 week babies do come. Like we do have those babies. They end up in an incubator for a while. They may end up being relatively okay, but that actually is almost a separate conversation.
Yeah.
When you're pre-viable, 20 weeks, 21 weeks, 22 weeks, even up to 23 weeks, we have this pre-viable space during which it's your last shot. And this is actually the thing that is most restricted around the country, but not in Pittsburgh, not at this center, not at UPMC. People gave her that option to induce, or we do what's called a dilation and evacuation, which is as brutal as anybody can possibly imagine. You don't get an intact baby. You don't hold your baby if you're doing an extraction or an evacuation. On the other hand, she didn't want to give birth to a stillborn.
Right.
It was just too hard for her. So she's left with a hard decision or an impossible decision.
Yep.
And she decided, you know what? I don't want to be more connected to this baby. I'm putting, this is my language. I'm imagining that a mother going through this would say something like, if this is ultimately the outcome that I'm looking at in the future, let's just cut our losses now. And it absolutely shredded her heart to do this. I was with her from start to finish, and it was terrible. It was absolutely terrible. On the other hand, what would her life have been had she experienced the death of a baby inside the uterus or a death of a baby shortly after the birth? We don't know. But that's actually not our business. It's actually her business. And it's her grief that has to be witnessed by her and her partner and everybody else involved. So,
the baby was
yeah,
going to pass. So in these situations, I would love to know, like,
right.
what does somebody argue against that? Like, what do we think is morally best for the baby's experience? Okay, here is one thing I actually question in that situation, and this is something that I have a really hard time finding online, this information. Is there routine, atropine or other medications given to stop the fetal heartbeat prior to something like a D&E at that phase? Or is the baby alive when it's occurring?
That's a very good question. Typically, we would offer some means of stopping the baby's heart,
Okay, because
meaning
I
the
feel
baby
like
goes to
that is
sleep.
a, yeah,
Yeah.
sorry, I feel like that should be a non-negotiable
Hmm.
because the baby is alive. And also, as they become more and more developed, we know that like they can feel pain and they do, they are not viable outside of this uterus, but it does
Right.
not mean that we don't care about them and that they can't feel pain. I think that it should be if there is at all the ability to stop the fetal heartbeat first. And yes, that's sad. And I'm sure in that moment that's scary. But what would be worse, right? This
Mm-hmm.
is one of those little things that I don't hear anybody talking about, and I don't really understand why that's not more of a standard of care. I think it should be. So,
Yeah.
and it would show more reverence for life. It would be like, we're doing this thing. I mean, or what would be worse is the baby being born and then passing away through suffocation from lack of oxygenation
Right.
from the placenta not being able to intake into the
Right.
lungs. Like,
Right. Right.
we're splitting hairs here in certain instances. I think there is a big difference between being pulled out and your body dismembered while you were alive. That to me feels really different than
Yeah.
one of the others, having a quick heart. I mean, it's essentially a heart attack, right? You put them in a cardiac arrest. So this is
Sort
one of
of.
those little
Yeah.
things that I'm like,
Yeah.
why can't we talk about this? Because I feel like we should be able to talk about this, that if we're going to do it, we could do it better. There are ways to do it better on a standard of care where she shouldn't even have been a part of that conversation. She wouldn't have to even be thinking about that. It should just be the way that it's done for the morality of it. I mean, if we're offering, is there negatives to the woman? I mean, from what I've researched, no, it's very local. It's not going to cause reactions. It's not going to cause any harm to her body. I don't know. Anyway, sorry. I just had to like say that
Well,
because it's one of my points where I feel like we could do this better.
right. So let's, in order to do that, you use the word pain. We have to unpack what pain is. And remember, my subspecialty, I've got a second board certification. That whole board's certification thing, I did it twice because I just love inflicting harm on my own psyche.
Yeah, I was gonna say,
Um,
ah,
yeah, and in hospice and palliative medicine, which is largely the care along a continuum of a life-limiting condition, like let's say heart disease or COPD or cancer, and it's inclusive of the very end of life, and when we treat pain, people tend to overutilize opioids. We actually tend to overutilize opioids in C-sections as well. That's another thing that people come after me about. But the point here is not all pain is treatable with opioids. In fact, quite a bit of the pain people experience at end of life and in childbirth is it's psychic pain. And I don't mean like Edgar Casey psychic. I mean mental and emotional pain.
mm-hmm.
So going back to, the morality, the state of Indiana I believe it's in Indiana, does not let you issue or administer, let's say, medication for a medical abortion unless you're seen in person. It's either Indiana or Missouri, I can't remember. But anyways, that one of the stipulations is if you want to have a medical abortion for any reason, it doesn't really matter what the reason is, you have to have a pelvic exam. And as a doctor who's done thousands of pelvic exams, I can say without any doubt that there is no benefit to me shoving my hands inside of you when you're already going through the duress around a conversation within yourself and with your partner around whether or not to terminate a pregnancy. Even if it is much, you don't want kids, even if the condom broke, even if your life's at risk or whatever. It's not an easy decision. And now I'm forcing my hand inside of you. I'm forcing you to have that in order to just take pills that are going to end this whole thing. So when we say we don't want to inflict pain, we have to also consider, okay, we're going to do an amniocentesis. That's a big ass needle that we go all the way through your abdomen, and you're already feeling emotionally or mentally discombobulated over this. And now I'm going to inflict physical pain. So we also have to consider, are we inflicting pain on the woman through an unnecessary additional needle stick into her abdomen? or through the vagina in order to inject, potassium chloride or whatever it is in order to stop the baby's heart.
Right. Like it's net pain. We need to look at all the forms of pain.
Right, right. I mean, people even at end of life experience existential pain. Is the way to treat that with opioids? Not if you're Buddhist. If you're Buddhist, you actually want to be connected to the end of life, the dying process as a part of completing your dharma. So so when you start to unpack like what is pain, and if a person's in pain or if we're inflicting pain, that's amoral. Well, that actually also needs to be, we need to
Move
unpack
through.
that, and we can't do that here because there's entire philosophies around this. So whenever there's this giant gray area, we have to also bear in mind that this person is an autonomous being. And if you're willing to say, well, inflicting pain is amoral, what is the life of a child with, let's say, trisomy 18, anencephaly, no brain? They are not going to live. They might live 3 minutes, 3 days, 3 weeks, 3 months, doesn't really matter. Is that individual going to be in pain? And how do we qualify or even quantify pain? We can't. So there are so many levels to this conversation that if you're just saying abortion is murder, you're either not intelligent or you're just not willing to be wrong or to be curious about something.
And go
And I like to give
deeper.
people the benefit. Yeah, like if
Yes.
you go deeper, then your eyes and your heart would open up a little bit. But the reason we're not having that conversation that you brought up, Morgan, around ending the fetus's life by stopping their heart, that is not somewhere people want to go because they're not compelled to go there because it's black and white. Abortion is murder. And I just gave an example in which the consequences of not intervening in this person's pregnancy could have left a wake of immeasurable pain for the rest of that family's life and that baby's life. So is it right or wrong? I don't know. But it's not really my prerogative to say what's right or wrong. It's my prerogative to try to understand who you are and where you want to go and how I can rally healthcare resources around you to make sure that we at least minimize the totality of pain for you, your partner, your family, your baby, all of that. And there's never a clear answer as to how to do that.
Snaps to that. That's exactly what it is. That's literally exactly what it is. And I think it brings up quality of life, which is a whole rabbit hole we could go down. And nobody has a crystal ball. But with some of these things where babies are going to be born on the cusp too early, might spend 6 months in the NICU, might never have normal quality of life,
Right.
might be on
Right.
medications their entire life. What is that? And I can predict probably the pro-life world would say, well, no, that was their path. That's God's plan. That's, what this individual was meant to go through. And because they still had a heartbeat, it's like their heartbeat is where there's this black and white line drawn. And I think that what we're saying is that there is more nuance and complicated external
Right.
factors. There's multiple cogs in the wheel turning this whole big idea, this concept to be considering. Heartbeat is one. Heartbeat is
Right.
one cog, and it's important. I understand, and I totally have reverence for life. Being a mother and having children is the best thing that has ever happened to me in my life. And it's my life's work. It's so important. I have extreme reverence for life and the way that babies are born and treated as whole people. And I
Yep.
think that that also matters then on the back end of this. Like, what about the children that are going to be born into a situation where they are not there
Yeah.
of women on the street or are
In
abused
foster
or
care
yes or
or
in a
whatever. Yeah.
exactly. And of course there will always be the heroic amazing experiences and stories which are really inspiring of the single mother who beat all odds, was the salmon going up the stream that worked the jobs and did the things, and the child that she had that she almost aborted completely changed her life and brought her
Hmm.
like to this amazing place of peace. And she rose above, she became clean, like whatever it was. There's always going to be those stories. And I think that we have to just not be unrealistic to idealize those stories as the norm. It's
Right.
just, I wish, obviously, of course, I wish my
Of
little
course.
innocent, sweet heart wants that to be the way. I want everyone to be able to be natural in every sense of the word. That, I have that skin bag bias or whatever. Like I want as a naturopathic doctor, I always have to check myself. Like things do happen. People do get sick. This does happen. There's horrific things. We do need medication. We need antibiotics. Thank God we do. Thank God
Yeah.
we have
Yeah.
C-sections. Thank God we have all these
Totally.
things, and it's like, but we have to remember that those sorts of stories are far and few between. And that's why we hear about them because books are written and movies are made and all sorts
Right.
of stuff.
Right.
And it's just not something that we can expect out of every single situation. And one thing too I wanted to bring up is your one of your points was about community, family members, and how, we don't have that village that we grew up. And as an anthropologist at heart, I think that is a huge root cause of this whole issue is the lack of the community structures. And now churches will say, and this is a beautiful aspect of some churches, not all churches are doing this, but they will say, like, we will support you. And it is a biblical tenet I've learned from my friends that, the people of the church rally around the women who are the widows, the single mothers, the ones who've become pregnant and are going to have a hard time with it, and that they should be helping in the raising of that child, whether it's financial or actual support of childcare, whatever it is. It's just that that is not actually feasible to everyone. In certain
Right.
small pockets, yes, maybe, and that's a huge privilege and amazing, beautiful thing that happens. Super, super supportive of that. It's just not a big enough structure in the whole in our whole country to rely on that. And even getting to the point of adoption, we have to think about speaking of pain, the mental emotional pain of that process, if she can even carry it, if she can do things. And then this brings into the paternal responsibility side that is lacking so greatly of,
Yeah.
as another root cause base. And I don't know what the solution would be for that because if all my solutions I've come up with sound very big government, like Big Brother breathing down your neck, paternity test,
Sure.
and forced laws of caring for even starting at the pregnancy. Because some women are going to be they're going to have a placenta previa or a shortened cervix. They're going to be put on bed rest and not
Mhm.
be able to work for 6 months of their pregnancy. And with no outside financial support from the other person who's 50% of this equation and this baby, how is she meant to do that? Like these are questions that no one is bringing up and in the ability to understand what is happening for the decision making that's happening. Like men just get off scot free. It's kind of crazy. I mean, and then yes, after the baby's born, if paternity can be established legally, then now he has to pay child support. And that's a whole
Does that fix any problem anyways? Like it's not just dollars. It's
yeah,
also
it's all the
like,
mental, emotional, everything, the time spent.
yeah.
I
Yeah.
mean, I learned in this postpartum class that I took one time that it's an insane tenet when we think about where we've come from in indigenous cultures. It's an insane tenet to think that a two-parent household would raise a one child. It's too big of
Yeah.
a job for two people. And that it was never meant to be that way. It was never seen that way. It was always a community kind of event. And the community knew that this new baby was going to one day grow up and be an important community member to the whole
That's right.
cycle and, working, contributing, taking care of things. And it was just this, and that's obviously not the whole reason why they would do it. It was inherently because it's a human and a baby and they love it and whatever. But it's like this beautiful cycle that works when it's in this smaller, less complicated, less segregated, divided, like you were mentioning about rural versus city. It's so different. Like the rural versus city thing, I think, is actually a huge, huge problem with America and why all of our politics conflict because the two are so different. It's almost like you're living in a completely different country. And the laws and the way that they have to try to span the umbrella of both settings can be very restrictive and almost suffocating to some where they're trying to get little small businesses done and da da da. And then they have to be there to support sometimes like, the chaos that's happening from the big city. Like it's just really difficult. But so these two opposing views trying to look in on each other, I don't know. I just think there's so many root causes that should be more of the focus when we're trying to figure out what is the solution to abortion. Like I personally think we have to have it and there should be restrictions, support. There should be more options laid out and there's this counseling aspect that should happen ahead of time to be in a very supportive way, not in a like the picketers outside of Planned Parenthood making everybody feel terrible. It's like, what if they were
Yeah.
standing there offering the options? Like, no one is going
Right.
to make a decision and say, oh my God, okay, they say this picture of this torn apart fetus on a big billboard sign. No one's going to like that. That is not how we support the people to not make this decision. What you do is you say, hey, here's the numbers for these adoption clinics, or here's some extra support that we have. Here's some finances that we've rallied to provide for you because you're doing this alone and this is so difficult. But usually it's those same people then that are actually really bashing the welfare side of
Right.
politics, and
Yeah.
saying, no,
Yeah.
because people are going to take advantage of that. And it's like, well, what do you want them to do? What do you want them
Yeah.
to do? You
Yeah.
want to be able to use community resources. You want to be able to rally other people's Isn't that exactly what this is? This is to support people when they're down on, like, in such a bad place usually of this mental emotional decision, that they're willing to do this and they understand the repercussions. But it's the other side is more painful, causes more suffering in the net, in the big scheme of things. And it's like, if we're going to help so that we can get more babies to be born in a situation that are going to be able to be cared for, those options are the ones that needs to be given in those moments,
Right.
not this like very shamey, very, I don't know. I just wonder what they think is happening in that, because it just is not the way. It's not the way to change somebody's mind when they're down on the dumps. They need to see that there's a light at the end of the tunnel, that there could be beautiful things that come from this if they're given a little bit of time to counsel it on it, and figure it out. But I think also, just like at some point I want to wrap up, or not wrap up, but get to the medical versions of why
Yeah.
things happen, because there's a huge portion of the country that does not believe that there is any medical reason for
Hmm.
abortion other than ectopic, like I was
Yeah.
mentioning earlier. And there's maybe not a ton of them, but it's simply not true that there's none. And we need to really get clear about that, because these are the people I think that are then influencing the votes of other people when policymakers are saying, nope, full 6-week restriction no matter what. And it's like, okay, well, what about that window between 3 weeks? I find out I'm pregnant very early. I have immediate symptoms. So I'm 3 weeks pregnant when I find out, usually.
Yeah.
3
And
weeks
that's
and 3
good for
days.
you. Yeah.
Yeah,
Yeah.
exactly.
Yeah.
But what about until my baby has a heartbeat? What about that gray area of legality? That's 3 weeks where I know I'm pregnant. What happens then? What about, there's just all these little things that these laws are not taking into account. Or, for instance, just one medical thing to bring up is the idea that a woman is having a miscarriage. So she is actively miscarrying. Cervix is opening. There's blood coming out. And sometimes miscarriages are really quite simple. It's still
Hmm.
painful and crampy and clotty and devastating. But sometimes, the uterus does its thing. It contracts. All of the products of conception is what it's called. All of the parts of the thickened lining, the uterus, the fetus, whatever, not the uterus, the placenta and the fetus come out clean and smooth and everything's perfect and fine. But sometimes miscarriages go on to bleed a lot, and they have a really hard time stopping bleeding. And there's probably some other things that could be done, maybe with herbs or whatever. There's other things, but sometimes you don't have time for that because it's literally the woman's life is at risk. She's losing so much blood, but the baby may still have a heartbeat. And now this is a
Mm.
situation I think no one thinks about. And this is a situation where the clinicians are caught in a really, really hard place,
Hmm.
because the law states you cannot, an abortion would be removing a baby that has a heartbeat still. But maybe this baby's heartbeat is 70 beats per minute because they are actively passing away. And it's horrible and tragic. And I'm not trying to act like that doesn't matter, because of course it matters. And do we not see the writing on the wall? This baby is 12 weeks, is never, ever going to live. But
Right.
now doctors are in a situation where they can't touch her until the heartbeat has stopped. But guess who might die prior to that? Is the woman.
Mm.
If we do not do something, which would be a D&C at that point, correct? Not a D&E.
Right.
Right. To stop, to cure, you're going to go in, scrape everything out. You're going to stop the bleeding. Usually there's some kind of a clot in the way, or a piece of the placenta hasn't, whatever. The uterus is very vascular and it can bleed a lot very quickly. And so in those situations, that's a life-saving procedure. And the laws in some of these states do not recognize that in a way that makes sense to be preserving life overall, because you're going to trade the life of a already dying fetus for the life of a living, currently breathing, contributing woman with her whole life ahead of her, who also may be a mother of other children. It
Yeah.
makes no sense. It makes no sense.
Yeah. Yeah.
And now a word from our sponsor. As we're talking about birth and postpartum support, I want to share my favorite reproductive health nutrition brand, Needed. Pregnancy and postpartum are the most nutritionally demanding phases of a woman's life. Many women will stop their prenatal after birth, but we actually recommend continuing it for at least the first 9 months postpartum and longer if you're breastfeeding. Needed's prenatal multivitamin is the most robust formula I've ever seen, and it contains the bioavailable nutrients you need in evidence-based dosages, which are well above the bare minimums that most prenatals settle for. Their quality standards are also top tier, with transparent sourcing and rigorous third-party testing, and that is why now over 6,000 practitioners recommend Needed. Now also we have the results from their IRB-approved clinical study, which confirms what we see clinically, that women who take the Needed prenatal multi had significantly higher blood levels of nutrients critical for postpartum and beyond, including vitamin D, B6, B12, riboflavin, K2, and selenium. Only women in the Needed group reached the sufficient levels of vitamin D, which plays a big role in immune health, energy, and mood regulation, all so important during the postpartum season. So while there are many ways to support yourself postpartum, continuing your prenatal is one of the simplest, most impactful and ways to do it, and Needed makes it easy. So learn more at thisisneeded.com/thrive to see more about this study, and use code HEALTHYMOTHER for 20% off of your first order. Yes, Healthy Mother, as a little mantra or affirmation for yourself. It's so cool. Okay, now back to the show.
Well, the types of scenarios that you're bringing up, let's go beyond the first trimester. It's a little bit easier to look at this whenever the baby's already reached viability, because we have a lot of really great options for, not great options in the sense that they're so easy and wonderful. But the D&C, the D&E, the medical abortions, up until about 23, 24 weeks, those are going to be available in some place. Like you can go and get that. Where I think we actually end up with, well, I'll take your example to begin with. So you've got a threatened miscarriage. There's not much we can do. Mom is bleeding, and baby's heart rate's not looking great. What do we do there? Mom's actively bleeding. What are we going to do? Like you said, you have to take care of that. And it's going to result, in order to save mom, in this case, it probably will require us to do an abortion. But I say probably because it's not clear. If it's at the 25-week mark, let's talk about that. That's viable. The baby can survive. Very, very likely will develop some degree of cerebral palsy, which is essentially due to the instability of this really, really premature nervous system. You just end up with some degree of hypoxic injury. If we were to save the mom by evacuating the baby, whether it's by C-section or however else, usually we're not going to induce that labor unless the labor is already happening, because these little babies are like so delicate. I mean, they're tiny little babies. So maybe we do a C-section, right? And maybe the baby's breech or something too. Like we'll just make it really, really complicated. So we do a C-section and we put that baby in the NICU. In the places where abortion is actually hardest to get, as I mentioned, healthcare is not great. And to get to a level 3 or level 4 NICU, you're going to probably have to travel, meaning you're taking off work. Somebody's going to have to pay for lodging. Somebody's going to pay for transport. You're going to be separated from your family, perhaps, or the whole family has to go down there. Dad has to take off work. Like, who knows? But who's going to pay for that? That's the first thing. So the same people that want less government, they want more government regulation, do not want to also support the other aspects of our social safety nets that actually make this stuff possible. Okay, I want to save my baby, but I can't financially afford to save my baby. I mean, imagine that, right? But let's say that you do save the baby and the baby does get to the NICU. A day in the NICU ranges anywhere from $5,000 to $20,000 a day, depending on the level of care. And those preterm babies, I'll tell you a story in a second where this actually becomes real. Those extremely preterm babies that are just barely viable, the 24 and a half, 25 weekers, 26 weekers, they're going to need the best, highest level NICU care. Is that down the street from you in Idaho, or is it across the way in another state? What about if you're in Alabama? You probably don't even have a level 4 NICU center except at maybe one of the big cities. And most people in Alabama are not living in those cities. Well, I shouldn't say most people. The people that this story might actually be, most relevant to, who are really torn between do we abort, do we do whatever, they may decide I want to go there. They go to the NICU. Nobody's going to pay for all the transport, the lodging, all of that. Nobody's going to pay for the time off work. Who's going to pay for the $30,000 a day bill in the NICU, right? Maybe they've got insurance that will cover that. Probably not. There's a good chance that you're going to still be hit with a pretty darn large deductible alone, which might be $6,000. Um, and then, of course, after you hit a certain cap, not to mention the emotional, the mental well-being of the family and all the therapy that's going to have to come into play. And how do we even get this baby back home safely? And how many months is this baby going to be in the NICU? We end up with this really, really, really tricky situation, which I don't have to go any further about. So let me give you an example where this might actually happen. Doctor, in what scenario could you possibly even imagine that? That's baloney. I never heard that on CNN or Fox News or any of these corrupt media networks that we give a little bit too much attention to. There was a woman who came in. I told you a brief version of this story a little bit ago, Morgan. She came in and she was blue in the face, came into the ER. She's pregnant. She's 18 weeks pregnant, something like that. And I remember the details of this because it was so bizarre what we were actually being faced with. This is a woman who was born with a pretty gnarly heart defect that required some reconstructive surgery as a baby. And that happens. But depending on the severity of that and how well the body, adapts to the modified, reconstructed cardiovascular system, you may ultimately end up living a life where you're short of breath all the time. You know, you can push it, but you're not going to push it too hard because you get very, very quickly short of breath on like a treadmill or something. So you just have to take it easy. You're not going up any big hills. You're not competing in Ironman or CrossFit or High Rocks or whatever, the workout du jour. You're just kind of living life. And you have this crazy story with a massive scar across your chest just to show like, whoa, you had an incredible childhood, right? Those types of women are oftentimes counseled against getting pregnant. But she fell in love. She and her partner said, screw it, we're going to get pregnant. And they did. So she's, late 20s or something like that. She comes in, she's blue in the face, she's pregnant, and she's pre-viable. We recommend actually interrupting this pregnancy because you, miss, are requiring supplemental oxygen at 18 weeks. We aren't even in the third trimester. And we know, everybody who's been pregnant knows, the physiologic changes make it very, very hard, not only for you to survive that ongoing journey through pregnancy, but also that baby's not getting enough nourishment. So this baby was small, and this issue with oxygen and electron exchange in the lungs was not sufficient for this baby to do well. But the baby was alive and was actually doing fine at that point. So at what point will this baby not be doing well, if ever? We have no idea. But miss, you're blue in the face. And we know you've got this crazy history, cardiac history. I don't want to terminate. We really want a child. Okay. She goes home and comes back the next week. She's even more blue. She's like huffing and puffing now. Baby's a little bit bigger. We're now at 18 or 19, 20 weeks. We're hitting the point where we almost are out of options, right? We can keep going here, but we're going to keep you in the hospital just in case you need CPR. And if you need CPR, that means your baby's long gone. She's alive at 21 weeks, 22 weeks, 23 weeks, 24 weeks, 25 weeks. She's now in that magical, you're now viable space. Suddenly now you become a pumpkin, and now we've got a baby that can survive outside the uterus, and we have a mom who's barely surviving in her pregnancy. We put her in the cardiac ICU, and we're just waiting for the call where her heart stops beating. Like this has overwhelmed her system. The baby is still growing incrementally, very, very small baby, but still growing, still keeping up, still keeping on. But we were so worried about her health at this point, and now we don't have an option to, quote, terminate the pregnancy, which, by the way, for those who use the term terminate or abort, you can just say interrupt the pregnancy. I actually think that's a little bit more gentle. We would interrupt the pregnancy in order to save you, but now we don't have that option. So I'm walking around listening for a code blue, which in most hospitals, at least where I trained in residency, that was like, we have a cardiac arrest, bring the crash cart, we're doing full-blown CPR, like all the stuff you see on TV. The problem is you can't do CPR with a pregnant belly. You just can't do it. It doesn't work that way. Partly because there's a decrease in venous return, and there's so much cardiac output going to the uterus that it's just not an efficient, it doesn't work well when you're pregnant. So what we were planning to do, if we got a code blue, was to run to whatever, bed 14 in the ICU, and we were going to do what's called a perimortem cesarean delivery. Meaning all I need is a pair of gloves and I need a scalpel, a very fresh scalpel. And I carried them around in my pocket. And every time that like ding went off, it was like, oh my God, is it ICU bed, whatever, 14? No, it's not that one. But if it was code blue, bed 14, ICU, I was going to run down there, get everybody out of the way, and slash and remove a baby. And then maybe we try to bring her back to life, which is what CPR is. It is bringing you back from the dead.
Wow.
Ultimately, ultimately, that baby died. If I recall correctly, I don't remember, but that baby did not. We did not have a 37-week baby that where mom was like, "See, I beat the odds." That was not the situation. And she had gotten so blue, so cyanotic, as we say, that we had her on a rebreather, meaning we're pumping air into your lungs. We're forcing it into your lungs in hopes that we can get enough oxygen to keep you alive and maybe even sustain the pregnancy. So, what's the right thing to do there? The pro-life people, if you're pro-life, you have to see that there's a life here who actually beat the odds when they were, 2 days old in their cardiac reconstruction. That was God's plan. And now, are you saying that God's plan is for her to die in order for this other baby to live? And that baby is going to be a 25-week, NICU baby in an incubator for God knows how long. The father's now going to be caring for that baby alone. And this baby is going to likely have some neurologic deficit. I'm not going to say every baby with cerebral palsy does poorly, but there's a very, very good chance this kid's not going to live a normal life. Is going to need a lot of social support, at least in the early years, if not for the rest of their life. Who's going to pay for that? Who's going to support the dad? So this whole thing, when you start to become granular with these different stories, you realize that this is not black and white. There's not a right or wrong answer. I don't blame that woman for wanting to be pregnant. She desperately wanted a child. And you as well as I know, this is a real gift. Like what a blessing to have children. I mean, I love having kids, my little girls. But gosh, that shows like the drive, that primal instinct to have children. All so much so that she was like, I'd rather die than terminate this pregnancy. I mean, this is where the complexity, this is where our real ethical conversations come up. And we did have to consult ethics and figure out like, what are we supposed to do here? Um, but I don't hear the clinicians telling these stories on CNN or Fox News. All I hear is a bunch of people in suits who have no business talking about a woman's autonomy over her body. Somebody who doesn't even appreciate what true informed consent or radical responsibility really means. And in that person's case, looking back, I'm like, dang, like she's a gangster. Like she was willing to say, I'm willing to die for this. It's very similar to the conversation around free birth. Not many people die in free giving birth, fortunately, in our country. But if you're willing to say, I know that that's a possibility here, or if you decline a C-section and you say, over my dead body, are you cutting into me again? And if my baby dies, then that's God's plan. That's no different from this pro-life, pro-choice conversation. And yet people get so caught in the weeds because of what the media and the legislators and all these people that really have no business over what Morgan does with her body. When they start to muddy the water, I understand now why it's become so divisive. But hopefully some of these stories will help people appreciate some of the nuance.
Yeah, thank you for sharing. And that's such a good point about, first of all, I just feel for this woman and her
Yeah.
choice making, or the other story you shared about the baby that had all the, birth anomalies, birth defects, as we could call them, that were not going to be compatible with life. It's like these decisions are heartbreaking and also important. And now some people might think, well, these little case studies that you guys are picking out are so nitpicky and so rare, and the real
Hmm.
issue is blah, 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 blah. And it's like, well, we just wanted to highlight for those that are thinking here's just a couple other medical reasons why people would maybe have an abortion, just so you know. If a mother's cancer diagnosis, a new cancer diagnosis during
Yeah. Good,
pregnancy
good example.
would necessitate treatment that is going to just kill the baby or cause extreme birth defects, then that's a situation where we end the pregnancy so that we can keep mom alive, a woman alive who's already here, who's already made it, and is potentially also already a mother. But even if she's not, it doesn't matter. She doesn't have to be a mother to be valuable. She's inherently valuable as she is. But this pregnancy is potentially going to interfere with her ability to live and beat cancer. I do know of situations where people have been treated with cancer while pregnant and the baby is okay, but obviously there's many different kinds of cancers, many different kinds of treatments. So I just want everybody to be able to have a reasonable compassion for that situation. Like you just mentioned about this heart defect, maternal heart failure or like a pulmonary hypertension that a woman had prior to pregnancy that can be worsened in pregnancy. Often, like you mentioned, these people are told they shouldn't probably get pregnant, but as we know, actually, I found a statistic that said 51% of women who seek abortion care were on contraceptions On
Interesting.
contraceptive, yeah, they either were on the pill, they used a condom, or they had an IUD placed. So they were making all efforts possible to not become pregnant. So it happens though sometimes, these things are not 100%. Okay, so one thing we actually need to get clear, which you should have done in the
Sure.
beginning, is that you've used medical abortion, which means the pills, right? So it's like
Yeah.
misoprostol, mifeprest.
Mifepristone followed by misoprostol is that's like the granddaddy package, but you can also just use misoprostol if mifepristone isn't available, which is sort of an ongoing issue in our country.
Is that because of the laws or because of like
Mhm.
manufacturing?
No, the laws.
And so does misoprostol on its own work well enough? Is that, or what's the issue?
It just increases the likelihood of it being successful. Mifepristone blocks progesterone receptors. You need a lot of progesterone around, and so mifepristone doing that first, it sort of like greases the wheels, and then the misoprostol actually helps to sort of end it,
Expel. Okay.
spell
So
it.
there's that, or you can go in and have a DNC or a DNE. DNC is used when it's not, so dilation and curettage, I feel like is
Mhm.
used if there's like a miscarriage that needs to then be helped medically, a missed miscarriage potentially. The woman knows that the baby's heartbeat has stopped, but the body has not caught up to this situation and has not started to bleed or open the cervix or have contractions or anything. So they'll go in and they'll do that.
Mhm.
Why though? What are the little delineation between when a DNC versus a DNE is used?
A D&E so a dilation and curettage, we use these little metal rods called dilators that you actually use to just gently encourage the cervix to sort of relax itself and open. Um, those dilators only get so big, but that's okay because the pregnancy, what we call the products of conception, which includes the embryo, the yolk sac, early placenta, the amniotic sac, all of that can be removed very, very easily through maybe a dime-sized opening. When you get beyond that and the bones start becoming a little bit more bony, if you try to pull parts through the small opening that's made by those dilators, you can tear, you can hit vessels and stuff. You have sharp stuff coming out. Whereas before that point, roughly before, let's say 14 to 16 weeks, you can usually get away with just removing everything through the dilation method. So the dilation and evacuation is a dilation, but not with the typical dilators. We use these osmotic, they're like, they can be made of natural, I think it's like made of like some sort of seaweed material. Dilapan S, I think, is the one that most people use. I always get the names wrong, but it's like almost like a silicon stick. And once you put it in there, osmotically, it draws water in and, secretions and all of that from the vagina. And then it slowly gets bigger. And you put several of those in there. And as they swell up over 24 to 48 hours, they cause the cervix to dilate to much greater than a dime size. So once you're doing the D&E, you actually go in with instruments and you crush and pull.
Yeah.
So it's a very, very different procedure because there's more formation of those bony parts, which is why that part, like the DNC is one thing. And you can do that on a totally normal first trimester pregnancy as well. Like it doesn't need to, you don't need to wait until, the heart stopped or anything. You just go and you clear everything out. Embryo is like a really, really tiny little thing. The D&E, you can actually have like parts that look like baby parts. So it's requires a specialist. I mean, there's very few generalists that are doing that procedure, but that's where the advanced training comes into play. And like I said, Morgan, for those listening, it sounds terrible. Like I sat through a couple of those and I was like, I can't,
I
I
can't
did
do
it because
this.
it's part of my training. I kind of wanted to see what it was about. And you have to. I mean, you're a resident. You don't say like I don't want to do that. I mean, I suppose you could get an exemption if you wanted, but for me, it was like if I'm going to be a women's health practitioner, I need to have all the skills, which is why I pursued breech training. I didn't get that in residency. I had to go and find that elsewhere. Like I wanted to know it all, and um, the people that do those D&Es, more power, yeah, more like you do you. It's just not for me. It's a really
Yeah,
really
I mean, it would be really hard as a human, even if the reasoning is to save the woman. I think that's such a visceral, embodied thing to witness. And when you were telling the story about the woman too, that you would have to do the very quick and kind of movie scene cesarean and then jump on her to perform CPR. Like people are not thinking of these situations, as you said, like this is what the clinicians know about. They see these situations happening and it's like it's almost unthinkable. It's really hard to imagine that there are things that happen like that and that that's how it would have to be, dealt with. And it's just really extreme and wild. And also, I think just important to highlight so that we can all have more compassion for the situations that people can be in. One additional one, like we mentioned earlier, was the preeclampsia. So it's rare to get preeclampsia so early on that the baby wouldn't be at viability yet, but it happens. And the only solution in that sense, if it was so extreme, if it was going into HELP syndrome or, an eclampsia, something, is to get the baby out and the baby is not going to live. And so that would be a situation where maybe some people would say, well, why don't you just induce? So this is one actually thing that people will say is instead of
Hmm.
doing a D&E, why don't you just induce? And then the baby can have, because it would be a more, and I can understand that. I can understand why it
Yeah.
would be more um pleasant, I guess, of an experience for a baby to be born and then die on the table in their mother's arm, whatever, or maybe during the process or something, I guess, than to be dismembered,
Mm.
crushed and dismembered. Obviously sounds horrific. And I, am very glad I've never had to go through that experience. But I don't even think that that's offered or a possibility. And I don't really know why. Can you speak to that? Why is that not something like, say I was 17 weeks, would I ever be offered to just induce?
You could, yeah, you could, in theory, you could induce that pregnancy. You have to bear in mind, again, going back to the bigger picture of pain.
Yeah.
Um,
And
my family
finances too.
member, well, it costs money to be in a hospital. So that's the first thing is the induction around those circumstances is done in a hospital setting. And that's because there's that greater hemorrhage risk. There's all that type of stuff. When a person's under sedation, they wake up and they're not pregnant anymore. And that actually, in some, if you were to look at it from that angle, there's some self-preservation there versus going through a childbirth experience and giving birth to a pregnancy that was maybe highly desired is just potentially very traumatizing as well. So on the one hand, you're asleep, we do the procedure, it's done, and then we pick up the pieces afterwards. On the other hand, we go through the induction, you give birth to a baby that isn't going to live. Maybe they're not even living, because you're pushing this baby out of the uterus and the uterus and the baby just aren't ready for that. You have the baby in your arms and you get that. That isn't definitely an alternative. Like you could do that, but some families, many families perhaps. In fact, I had two of these happen. One was a good friend of mine last year. This was both in 2024, and they both chose the procedure just to get it done with because they couldn't bear going through the childbirth experience for their first time. Both of them, it would have been their first time, and giving birth to a baby in that, under those circumstances. Do I think that there's a right or wrong? Part of me is like, maybe it's best to just go through the induction and go through it, but like, who am I? Like, I don't ever even have to give birth. It's easy for me to talk about childbirth, and people say, you're an expert in childbirth. No, I'm not. I've never had a baby. How could I be an expert in something I can never do?
Hmm.
So it's not I can pontificate and talk and use poetic language all day long, but given those two options, it does seem to me like a lot of people do tend to steer towards the kind of quick, sedate me, put me to sleep, and just get this over with. We actually just had another one just happen now, 25 weeks. I just got a call from one of the midwives that I work with, and she is at 25 weeks, so they're going to induce, but that means she's going to give birth to a baby that's no longer alive. And that is a pretty horrific thing for somebody to go through. So I
Mhm.
can see it from both directions.
And I can too, and I can see that some people will say, no, it closes the like to play devil's advocate. It
Yeah.
closes the loop. There's closure. There's she
Yeah.
knew she knew she lost the baby, or she knew she was going to, have an abortion. She gave birth to the baby, and like it's sort of this full thing versus maybe it feeling a little bit like not this like a little I don't know, like
Mhm.
that there's this like a body feeling that I get with the idea of just like waking up and then it's gone and being a little bit like
Yeah,
"Wait, what?"
totally.
So I could see that.
Totally.
And I think the larger point here is that, yeah, who are you or I to say which one is right for any woman everybody is, this reminds me of the conversation about epidurals. When some people love natural birth, they're all about it, they're physiological birthers, like they want to do it. That's me. Some people are very, very afraid of the pain, or they really felt they could not handle it in the moment. They really wanted, they were exhausted. They were first time moms in labor for 56 hours. They go get an epidural, whatever. It's like, who are you to say that that was not the right choice for that woman in that moment? And it's just that obviously this is now we're talking about a life here, but even further, we're talking about, well, which way
Yeah.
is it better for her to end the life of the baby? Is it better for her to have a
Right.
surgery,
Yeah, that's
or is it
exactly
better
right.
for,
Yeah.
it's like splitting hairs. But that is something though that I hear and that people really are feel very fired up about is like, nope, there's no situation where you should do this. You could just induce and let the baby, die on the table or die in your arms or something. And I'm like, I can see that, but I also can see that that would have potentially for some people
Yeah.
worse net outcomes. And everyone is different. And we just have to say, we have to have this compassion that, like, we're not in those shoes and support them, offer the other options that exist if they do. And also, like, if there's something that you're aware of, like if somebody is listening to this podcast and you feel very strongly that there should never be a reason for abortion, like, outside of now one of these medical things, which hopefully we've elucidated to you that there are real legitimate medical reasons why women have abortions to save their own life. Outside of that, the other reasons are not moot points just because it's not going to be life or death. It actually may be life or death somewhere on down the road, or a complete life of difficulty and challenge and misery, and then that child is born into a situation of domestic abuse and beat the shit out of their whole life
Yeah.
and raped by their own father. And like, there are women. I think that this is something nobody can really see, because if you're not in it, you couldn't see it. And it's something that really breaks my heart. It's not like I have a personal experience with this, thank God, or even a friend, but I can imagine a situation where a woman already has, say, two, three, four, something kids and is barely getting by every day. And her husband comes home and beats the shit out of her every night and rapes her. And she gets pregnant and she goes, oh my God, I cannot do this again. And some people are going, leave him, just leave him. Yeah, if
Yeah.
it was that easy, don't you think she wants to leave him? Like,
Yeah.
don't you think
Yeah.
she wants to do that? And they're like, well, call the crisis hotlines and stuff. And it's like, okay, that can only help to some extent. But if this woman is looking at her life and going, I can't leave him in this moment. I cannot, for the finances, for the whatever, because he's going to track us down and kill us. I mean, you guys, these
Yeah,
things
there's
happen.
just so these are real things. Yeah.
They are
The
real things. It's not fantasy books. Like, this is real. So she goes to the abortion clinic and she says, I cannot be pregnant anymore. Like, that is a real, I cannot bring another baby into this. I cannot do this again. I'm barely getting by keeping everyone alive right now from this, like,
Mhm.
monster that we live with?
Yeah.
And
Yeah.
I mean, that I guess would fall under well, maybe not. Maybe it wouldn't fall under legal, rape and incest laws that are there. But I
It
guess I
wouldn't.
just, for
Yeah.
compassion's sake, and now is this woman going to, like, tell the picketers outside of Planned Parenthood her story? And then what are they going to
Yeah.
do? Are they going to turn around and stage an
Right.
intervention and get their,
Right.
like, money from their churches all collected and get her new rent at a house and get her a restraining order and make sure that those babies that she does take care of are going to be safe from him? And so, like, these are real
Yeah.
questions that no one seems to have an answer to. So right now, the answer is abortion in that situation, for that woman in that situation, that luckily you, person who has a hard time understanding why people might choose this, are not in that situation. And thank God for it, because it would be horrible. And, like, right now, yes, there's so many systemic things that need to change, where we do have more support, where we do have more paternal responsibility, where we do have, like, more health education with the menstrual cycle so we can understand what's happening. So we have
Yeah, that's a big one.
it
Health
is a huge
class.
one.
Yeah,
And right
start talking
now,
about your cycles. Yeah.
yes,
Yeah.
and right now those systems are not in place to change the numbers that we're seeing of how many abortions need to take place every year. That is the goal. That should be strive for it. We need to continue on with that path deeply, strongly. But right now, in this microcosm moment of our lives, that's not what's happening. So we must be able to have this as an option for some of these situations. Like, I also think that we should not use it flippantly. I also think we should have reverence for life. I also think in some of those really gray areas where it's like, "Ah, I just don't want a baby yet," it's like, oh, that is harder for me personally, because I do feel like there are situations where we can be like, but Okay, all right, but like you did it, you did have sex, like, and I know that some people are going to come and attack me for that statement, but that is how I feel, where I feel like that one's harder for me to say, like, I think about my situation. If I was perimenopause and I was having really infrequent cycles and I didn't know if I where I was in my cycle and I'm 46 and then I get pregnant again and I've got four teenagers, like that would be a very that happens too, that would be a really hard situation for myself. But I just want to like my point I think is yes, we can attack or we can tackle the problem of abortion through these root systemic problems that have issues while still having compassion and understanding our neighbor for the reasons why they might choose it and understanding that this still has to be something that's available to women. And like I live in Idaho, it's an extremely restrictive state. People are moving away from the state. And some people are going to say, oh, yeah, well, okay, then
Doctors are
fine.
moving away to your state. Yeah.
Yeah, they're going to
Yeah.
say, oh, fine, leave because you want to like, go kill your baby or whatever. And it's like, that's not why they're, it's just they're leaving because they don't feel safe necessarily. It's for
Yeah.
various reasons. Also, or they're leaving literally like to just go to a sister state and get it done. I don't know. But there's also healthcare providers, OBGYNs and midwives who are leaving the state because they do not want to work here anymore because it is so restrictive, it is so confusing. And that doesn't fix anybody's problems either because, like you said, the states that have the highest poverty and these most restrictive laws do not already have very good healthcare for women. And now the doctors and midwives are leaving because they're like, I
Yeah.
can't even work here. Not
Right.
because they're performing so many abortions that that's their paycheck. Like, that's not what I mean. I mean that they don't feel like they can even take care of their patients properly because they cannot counsel on the situations like they should be able to do.
Yeah. Yeah. Um, if we, if we want to have, we either, believe in having more regulation from the state and the federal government, or we want less. Um, I think most people who are adamant about restrictions on abortion access are the same people that are like, over my dead body, are you gonna, talk to me that way when I'm pregnant? It's become a very, very strange. It's the opposite of a binary. And the advice I have for you in order anybody listening to think about this is that we saw this happen with COVID. When you give them an inch, they're going to take a mile. And this conversation around abortion doesn't have to be as politicized. It doesn't have to be this sort of religious dichotomy of right and wrong. It doesn't have to be any of that. But if you don't believe in a woman's right to access medical services, then you're going to take away abortion. You might as well take away their ability to um, to decline induction or to decline C-section or to have a vaginal breech baby or have your twins vaginally. You have to take all of that away. Just give that to the policymakers and let them decide for you. Or do we think that women are actually intelligent enough and that they have really, really felt their way through these hard things and that they're making the best decision possible for them? It doesn't need to be what I would do or you would do. What would they do? And if that's not at least considered in the conversation around abortion, then we're heading down a path that I don't like. I know people in Idaho don't like that. I know people in Maine don't like that. I know people in Texas, freedom, do not like that. But you can't pick and choose where a woman has the freedom or let's say the autonomy over her body. You can't pick and choose that. And the last thing I'll say is, you brought up the Planned Parenthood things, and as you're coming to this conversation, even those people who are picketing out in front of Planned Parenthood, the Christians that are calling me a murderer because I'm quote pro-abortion. I'm not pro anything. I'm actually pro caring for women, which is what I spent $500,000 learning how to do. Um, when they come your way, and you end up with these really, really hard conversations, bear in mind that there's probably a scenario in which they would likely agree with you. That's what you had said at the very beginning. And when I started my Planned Parenthood rotation, day one, I was a second year resident. I had no real, like, I was all about just like, if a woman wants this, that's great. I don't know if we'll have an abortion. We're not pregnant and we're not hoping to get pregnant in the near future. But I walk in and I have to go through this crowd of people and they see I'm holding a white coat. So they're like, "You're going to go kill some babies today?" I was like, "I wasn't planning on that. Like, who, can I help you?" Like, I was clueless. And they were like, yeah, just one of them, and I didn't realize like somebody might have a gun and just want to shoot me. I have no clue, but I'm walking in the front door, not knowing there's a back entry. And I started a conversation with them. And within like 5, 10 minutes, I was early, so I just figured I'll take some time out here. Within 5 or 10 minutes, we actually were having a reasonable conversation. I was like, yeah, I don't, like the language of killing babies, but I don't think the people in there go to work, counting the number of babies they're going to kill in their head. Like that's how they go to sleep. Oh, I killed 10 babies today. I'm pretty sure that that's not who they are. Like, have you talked to them? No, they won't talk to us. I'm like, well, is it because you guys look like an angry mob or, like, did you guys have breakfast? I mean, I actually said this to them. I
Right.
was talking to them. Like, did you guys get coffee and breakfast? Like, do you guys want to have a reasonable conversation? Because I'm all for living in the gray with you if that's what you want to do. But these signs you guys are having and these threats you're making, like, you're not going to get anywhere.
No.
Um, you're making people feel bad. Like, you're actually making people feel like you're an asshole. And I don't really want to talk to an asshole today. So we, had some chuckles and we were talking. I was like, listen, if you guys can leave your signs at home, I'll bring you coffee tomorrow. Cream,
Good.
sugar. I actually said this. And I walk in and the entire staff is there. They don't know me. I don't know them. I'm like, hey, I'm Nathan Riley. I'm an OBGYN resident. I'm here for like everybody's looking at me like I'm crazy. And I was like, and the boss comes out, the doctor, and she's like, go home. You're not ever welcome back here again.
No.
Yeah. So I called my program director and I was like, I just got fired from the Planned Parenthood site. And she's like, oh man, what did you do? And I was like, well, I was talking to the protesters. I was trying to understand like why they're so angry.
Why would you be
She's like,
fired for that?
yeah, you don't know why they're angry. I'm like, I know that they're people that have really strong opinions. I was trying to see if we could get like a dialogue going. She was like, no, you're there to do your job. And I'm like an MD. I'm like, I've got MD on my chest. Like I'm a
Dang.
grown man. And so they found another site for me to rotate at. But that little experience there was like, okay, so the doctors and the staff are also like they've been scared into this little brick building
Yep.
and they're not willing to have a conversation either. And so what we need now is more podcasts, more spaces where people actually can come to the table with an earnest desire to maybe even have their minds changed. But that's not what I'm seeing. When people message me on Instagram and they send all this terrible things about me and my family, your mother should have aborted you years ago, those types of things. Should she have, Mr. Christian? Like, would you have been okay with that had they aborted me? Like, I mean,
Jeez.
it's insane. Um, and they say about this, it's not just the abortion stuff, it's all kinds of things. If we could find a way for us to actually get together and have a reasonable conversation about this and get the people like me and other clinicians who are doing this work, they're actually having to bear witness to this and take care of people who are in like the throes of this terrible conversation within themselves, with their partner. They've got a whole story. If you're interested in hearing stories, we need to find a way for us to actually do this in a more responsible, compassionate way for one another, even as the objectors and whatnot, the pro-life, the pro-choice, whatever you want to call it. I will say again, we are all pro-life. Everybody wants babies and mothers to survive, and that's just not simply the world in which we live in right now.
Right.
So we have to have some way of mitigating the consequences of this. And you mentioned women's health. I mean, just teaching little girls that they have a fertile
Yes.
window every month. I
Yes.
know you do quite a bit of conversation around this. Like, and so I do
Yeah.
appreciate this conversation. This has
Yeah.
been,
I
a lot of
appreciate you
fun.
coming on. Thank you so much for sharing your wisdom with us. And you don't have to think it's the best way. But certainly, what's happening now with the inability for these conversations to take place on any kind of policy making stance in the media, I mean, the media is the worst thing in the world. Just stop watching the news. Like, throw away your TV. We don't even have one.
For real.
Yeah, it's all the same too. CNN, Fox, whatever. It's all the same. It's just like trying to rile you up, make you mad, and it's not even true. It's not even real. It's not even
Yeah.
true, and it's so extreme and just, I mean, it should be glaringly obvious to people, but it's not. So I'm just going to take a moment to say it that the future is only going to get more and more wild with AI and what is going on and what's happening. And the solution to that, the only one that I can see is community with ourselves and getting together and having as much compassion for each other and understanding as we possibly can have. And actually focusing on the root causes, which is not to say, no, you cannot do this right now, because right now it's a must. Now we can have rules, and I think we should. We should have reverence, and we should have counseling, and we should have options and things like that that are given. But we can also funnel all this energy that we have into the education of side of things and empowering men to be responsible for their choices too. It should not just be on the woman, and it is, and it's just a really complex conversation. So anyway, I hope that in this, you've maybe had a little bit of like insight, or it's been interesting, or it's maybe just piqued your curiosity, or maybe it's just made you feel a little uncomfortable because there's some kind of a shift happening, and
That's
maybe not.
exactly right. Say that again. No, say that again.
Maybe
For
you
the
should
people that
feel
are
a little
feeling a
bit,
little uncomfortable. Yeah.
yes, maybe you should feel a little bit uncomfortable because there's something in you that is starting to crumble away, to change, to shift, and you don't really know where it's going yet, and you're a little bit scared because it's not feeling safe. Your feet haven't landed there yet. You're kind of like, what's going on? That's a good thing. It's okay.
Good.
It's
It's
like being in
healthy.
transition. Yeah. You're in between worlds, and transitions always suck of all kinds, and they're not fun and they're not comfortable. But I think that we have to continue to push ourselves to just say, okay. And hey, listen, if none of your mind has changed and you're never going to listen to this podcast again, or you're going to whatever, that's
Just don't
okay
leave me a
too.
bad review.
Yeah. You don't need to tell me. But also, my thing that I would say to you with a huge, open, loving heart is that I think you need to like analyze that part of yourself that's feeling so triggered, I guess is not really quite the word I'm
Confronted,
going for, but yeah, that's it. That's the
challenged.
way you're feeling challenged. Yes. And explore deeper there because there's something there that I think can really change your life potentially to like open up, not necessarily to this conversation, but there's something that maybe needs to like break out. And if you look at it with some curious compassion, it might, be good for other parts of your life. Anyways, okay. Thank you so much, Nathan. I appreciate you. All of his information will be in the show notes, and we hope that you enjoy this conversation. Thanks for listening to this episode of the Healthy as a Mother podcast. In order for others to hear this information, please leave a review with Apple Podcasts, subscribe, and send to a friend who could benefit from this content. We're so excited to share more on becoming and being a mother next time.
And please remember that the ideas and views of this podcast are for informational purposes only and are not intended to serve as a substitute for medical care of any kind, including the diagnosis or treatment of any illness or disease. Consult with your provider before integrating this information into your own care plan. And remember, a healthier future starts now, and it starts with you.